which I have prepared earlier, hopefully, and go to can everybody see that okay?
Yeah.
Yeah, brilliant. So thank you, Alison, and the team. So I'll hand it over to you, and just let me know when you need me to flick over the slides.
Thank you and good afternoon. I'm Alison Sustakovsky. I'm one of the CVD Prevention Transformation Programme leads at the ICB, and thank Amy again for this opportunity this afternoon to come and talk to you about CVD prevention. I'm going to hand over to Marcia initially, and I'll let everybody just introduce themselves separately as they present their slides. So if we can just move on to the next one, if that's okay.
Right, hi everybody. So I'm Marcia Pathak, and for those who don't know, I'm a GP at Raj Medical Centre, which is on the edge of the Nunsthorpe estate in North East Lincolnshire in Grimsby, and I'm also the CVD prevention lead for North East Lincolnshire. So I'm here today to talk to you about the clinical implications of hypertension, and it sounds so dry, doesn't it? Nobody hears that and thinks, oh, sexy. That's something I really want to hear about. But I'm here to try and convince you that actually it's a really exciting subject. I think when you think about something like high blood pressure, which everybody knows somebody with high blood pressure, you know, you hear a lot about it. We almost get a bit kind of blasé about it. You know, it's just like, well, loads of people have got high blood pressure. Does it really mean anything? You know, does it really affect us? You know, is it really as bad as people say? Well, actually, yes. You know, if we look at people, as you can see from this graph, if we look at people who die from cardiovascular disease, so heart attack, stroke, similar sorts of illnesses, and if they then look at 100,000 of those people and they look at the prevalence of conditions which could have led to that cardiovascular disease. So really we're looking at potential causes of that cardiovascular disease. You can see that by far the highest correlation is with high blood pressure. So to put that in perspective, that's worse than cholesterol, it's worse than smoking, it's worse than having diabetes. You know, who's worried about air pollution? You know, it's worse than that. It's worse than not exercising. It's worse than eating loads of salt. You know, all of those things, you know, important, yes, but none of them gets even close to like the impact of high blood pressure on causing cardiovascular disease, which eventually leads to someone's death, because that's what we're talking about in this slide. So if ever, you know, I can persuade anybody about the importance of recognizing and treating high blood pressure, then this graph hopefully will convince you that it's worth doing. Next slide, please. So this is looking at trends both in England, which is the black line, and also in North East Lincolnshire, which is the sort of blue line with the different coloured dots. And as you can see, over time, sort of mortality from cardiovascular disease is reducing. And there's lots of reasons for that, you know, in terms of use of statins and reduced smoking rates and all sorts of things like that. But as you can see, North East Lincolnshire does sit above that England line really throughout, and it's got a lot more sort of variation in it than the sort of nice smooth England reduction, and possibly we're starting to see a little uptick at the end. You know, we'll have to watch this space, but certainly it tells us that there is a case for focusing on this area within North East Lincolnshire. Next slide, please. Yeah. And there's lots of work going on nationally now using kind of modelling and you know, sort of artificial intelligence and things like that. And what that allows us to do is it allows us to look at our population and the characteristics of our population, the deprivation, etc., the age of our population. And it allows us to compare us with other areas that are similar and to think about, in a population like ours, how many patients with high blood pressure would we expect to have, and how many therefore are missing from our general practice registers. And what we can see here is that there's an estimated, and you know, different figures all come slightly differently, but from our figures that we were looking at, our most recent figures, we were told that there's potentially 9,000 patients who are missing a diagnosis of hypertension who potentially have got hypertension, are in the community, and by hypertension I mean high blood pressure, and are not recognised or treated sufficiently. Next slide, please. So again, this is just a nice way to look at it. So the purple or the blue guy, whatever your eyes tell you, mine says bluish purple. This is the guy that GPs congratulate themselves about, or the lady. You know, we've recognised that they've got high blood pressure. We've followed them up. We've done a few readings. You know, we've recognised it, and we've started them on some treatment, and their blood pressure's come down to an acceptable level. So this patient, we've significantly reduced their risk of cardiovascular disease from their high blood pressure. Then we've got these kind of darker orange figures. Now, these are ones that we've recognised at the GP. We've probably done a few readings. We've started them on some treatment, but either we're struggling to get control of their blood pressure, and that might be because they've got other kind of lifestyle factors that are affecting the control. They might be very obese, or they might not be taking their medication properly. They might be drinking a lot of alcohol, which is giving them lots of higher readings. Or it might be that we've not really treated them with the right medication for them. It might be that they've got some kind of absorption problem, but whatever it is, the fact is we've not got their blood pressure down to that target range. So they are still at increased risk of cardiovascular disease. But in a way, they're visible patients. So they'll have a read code most likely. They'll be on some treatment. They'll probably be having a GP review. So we've got a good chance with them of picking them up again, providing we do our job properly at the GP surgeries. Now, the next patient, the paler orange patient, this is a patient who's aware that they've got high blood pressure, but they're untreated. Now, I've recently done a project at Raj Medical Centre where we looked at patients who have had a blood pressure reading that is raised out of range more than 3 months ago. So these aren't patients that we've taken one recently and we're waiting to do a repeat. These are patients that have had high blood pressure for a while. And we did a search on our patients 7,500, and we've got a very deprived population. We've got 60% of our patients living in IMD decile 1. And what we found was, embarrassingly, in our patient population of only 7,500, we had basically around 500 or 600 patients who potentially had high blood pressure that was untreated. So these were patients that didn't have a read code, weren't on medication, that we'd taken a blood pressure at some point that was raised, probably said to them, oh, we'll need to get that repeated. And then for whatever reason, they weren't followed up. That might be down to us not following them up. It might be down to them not turning up at appointments and we've not chased that up. But obviously that needed to be sorted out. So we've, over the last month, have gone hell for leather to try and get these patients in. And we've actually managed to reduce that number by around 200 patients. And what we found is around 140 of those, actually, when we've repeated, their blood pressures were fine. But there was around 60 patients that have been confirmed to have high blood pressure and have been commenced on treatment. And then we've got another cohort that they're a bit borderline. So we're doing some things like ambulatory blood pressures where they have lots of readings taken over 24 hours. So this is a really key group here that we should be following up in primary care, in general practice, and on top of. And they, again, are people that might be aware. The other thing is they might be frightened, they might be misinformed, they might not think it's important. They might just be too busy in their mind. So we need to think about what role could community services have here. You know, if they're working in a factory like 8 till 6 every day of the week, it might be that if there's blood pressure testing in the community at the weekends, you know, maybe through some of the providers, that they would have a really good opportunity to be able to get that blood pressure taken and address some of those health needs. And then we've got this really big group, I mean, nearly 50% of the group that potentially doesn't know they've got high blood pressure at all, has no idea. And we've identified through sending out some random blood pressure texts, you know, just saying to patients, can you get your blood pressure checked in the pharmacy? We've identified lots of patients that we just hadn't had a reading before, who've got really, really dangerously raised blood pressures, who are just walking around out there in the community at very high risk of cardiovascular disease, heart attacks, strokes, etc. So these are a cohort that actually I think we need to have some really creative thinking around, making every contact count, like we say, and thinking about innovative ways that we can get these blood pressures checked. Next slide, please. So I think this is a really powerful slide because it shows you the impact of treating high blood pressure. So actually the first blood pressure is completely normal, and we can see that, you know, that's nice low cardiovascular mortality risk. The next reading, actually the top reading isn't too bad at all. It's just at the upper range of normal, this. And you can see, even though that wouldn't be massively alarming, it still has doubled the cardiovascular risk. So your chance of mortality, of dying from a heart attack or stroke or similar sorts of conditions. Once you get up into 155/95, which is a very routine blood pressure that we sort of see people presenting with in primary care, and this wouldn't be a blood pressure, it'd be a, yeah, we need to get that repeated fairly soon. You can see that patient's now got a 4 times risk of dying of cardiovascular disease. And once you get up to 175/105, which I've processed around 3 or 4 blood pressures of this level today in my practice alone, you can see you've got an 8 times risk of cardiovascular mortality. And most of these patients will have no symptoms, none whatsoever. So they won't have a headache or visual disturbance or any of the other things. The vast majority of them don't have any symptoms at all from their high blood pressure. Next slide, please. Now, this is the one that really gets me, this slide, because I think prevention can be a bit of a thankless task, because if somebody has a cardiac arrest and you jump up and down on the chest and you get a heartbeat, everyone's slapping you on the back and congratulating you for saving that person's life. But prevention's a bit of a thankless task, really, because you're never ever going to know if you've prevented a heart attack or stroke, because these events often will happen way down the line. So really, I think figures like this for me really help, because it shows the impact of interventions. And I think let's think for a minute about if somebody goes into hospital with a heart attack, changes on their ECG, barn door heart attack, you know, life-threatening situation. And one of the historical kind of main treatments for this would be, you know, thrombolysis or what we call a PCI, which is where they put, you know, they basically clean out the artery with a sort of catheter. Now you can see on the PCI for an NSTEMI, which is a type of heart attack, you actually have to treat more than 200 patients, or you have to do that 200 times to prevent a death. Now, that doesn't mean that all the other patients die, but it means that some of them would have survived anyway, whether you'd done that or not. But in order to actually get that benefit, you have to do quite a lot of interventions, and it's quite a big intervention as well, you know, going to a cardiac catheter lab and having that done. Thrombolysis, which is the more old school traditional thing that we used to do, which was like clot busting, you know, giving strong anti-clotting agents. Again, 43 of those you would have to do to save 1 life over 30 days. And again, like, I would have just assumed that was far higher. When you compare that with treating someone's blood pressure, and potentially you would only have to treat 10 people over 5 years to save a cardiovascular death. And like, for me, that's major, because if you think back to the slide where how many missing patients did we have, Alison? I'm trying to think now, like nearly 9,000 patients.
Nearly 9, yeah.
Yeah. So if you think then that potentially you know, you only have to treat 10 of those over 5 years to save a life, then it's really clear that you could potentially save up to 900 deaths from cardiovascular disease from treating those 9. If we identified and treated to target all those patients, that's the potential for. And when you then think, you stop thinking about it like data, and you then think about each individual family, you know, 900 families, 900 granddads, 900 fathers, mothers, you know, sons. And when you think about the impact of preventing those 900 deaths, suddenly hypertension does seem a bit more sexy, and it does seem a bit more exciting, and it does seem a bit like something that we would want to focus on. So that's, I think, about me done, isn't it? But I hope I've just piqued your interest. I hope I've made you all feel a bit more excited about high blood pressure and about the reasons that we check it, the importance of identifying it, coding it, and treating it successfully. Yeah, if there's any support that anybody needs from me to start any projects, I'd be happy to assist.
Thank you. So taking on board all the things that Marcia just said then about the importance of knowing your numbers, the importance of understanding how high blood pressure works and the impact that can have on you. This campaign is run every year by Blood Pressure UK as a means to get people talking, get people understanding the importance of knowing your numbers from a high blood pressure perspective via a campaign that takes place every year. This year it's between the 8th and the 14th of September, and it's something that the ICB and all of our colleagues get behind, especially from a sort of CVD prevention perspective. Should we move on to the next slide if that's okay? So in terms of some of the support that we offer, well, every year we produce on our Humber North Yorkshire ICB communication campaign website, which I can put a link in the chat box. We prepare like a stakeholder comms toolkit. So on there, which is the where you can see the hands with the holding the heart. The number of resources that you can link on in there for posters, for Teams backgrounds, for social media templates that you can use. And whilst as an ICB we push out press releases and our own comms, we really hope that local authority colleagues, VCSE colleagues, stakeholders across the system use this toolkit to help push out those key messages so that people start to understand the importance of knowing the numbers. And this is a campaign that runs between the 8th and the 14th of September, but it's something that should be talked about throughout the year, like Marcia said, as part of making every contact count. And there's just some examples of some of the press releases. There was a plethora last year, there always is every year, and it's great to see them across the system where our colleagues have come together and sent out press releases and really just raising that profile. And I think sometimes what speaks louder are some of the studies where we can see what's happened, where you can start to understand what's happened to person in real life and the impact that knowing the numbers has had on them. So we do have some press releases going out that start to give some of the examples of how knowing the numbers has saved the lives of some people that have been involved in some of our projects. So we should be able to share with you some of those press releases as they fall next week. Next slide, if that's all right. So I guess my last plea before we did move on would be to please go to some of those resources. Please use your comms channels to get some of those key messages out, as it just takes one person with undiagnosed hypertension to read some of this and go and get a check that can be life-saving for them. We thought it'd be interesting just to give a flavour of some of the events and activities that took place in North East Links last year. I think I'm handing over to Amy and Gaynor just to talk about some of those.
Yeah, thanks, Alison. So we, with Health Innovation Yorkshire, who really kindly put on some trainer support for our Thrive social prescribers, we got them trained up so they could actually train their own staff, and they haven't since trained the wellbeing workers so that we can take blood pressure readings confidently and competently across North East Lincolnshire in outreach sessions. So last year was the first year we actually embarked on this, and managed to put together quite a lot of events in a relatively short period, because obviously not a lot happens in August. So we also got support from the three councillors. You see their councillors, Sheldon Mill, Janet Goodwin and Tim Mickleborough. Janet's now the Mayor of North East Lincolnshire, and Nunny's Farm is in the ward where Marcia has her practice, in South Ward, and so at Centre 4. And it was a really successful day in the summer. Families and lots of blood pressures were taken there, really helped to raise the profile. And then you see Amy sitting there on the left. It is a real picture. She did have a blood taken. It's not just a stage. Yeah, a blood pressure taken, not a blood taken. So so that was at the YMCA in Grimsby. All the Links Inspire members, so they Links Inspire run our leisure centres locally. They were all invited to have their blood pressures taken there, and we had blood pressure stations set up in the municipal offices where the ICB staff and council staff are based. So all in all, we pulled together a lot of events in a relatively short time, and it was a really successful week. And this year we've sort of gone for it a bit more with gusto. So Amy will explain some of the things we're doing this year.
Absolutely. So I was quite still really new into my post last year, but obviously this year I've been in here for a full year and working with Gainer and a lot of the networks that we've built up. We've decided to go with a real brilliant partnership approach to offering pressure stations throughout North East Lincolnshire. And I kind of set a target of 20 and we've reached that. So that's brilliant. And I'm pretty sure we're going to smash the 131 we did last year. We're going to smash that target as well. But how we're doing it is across the whole breadth of North East Lincolnshire. In the past, we have been kind of guilty of favouring one area over another. But what I think we've done this time is from Immingham all the way through to Cleethorpes and Grimsby, we've got a fair amount, over 20 stations, and more of that are coming in that we're having to roll over to the next week because we just don't have the capacity. So I think by the second week, we'll probably reach around 25 pressure stations that we've delivered. Gainer's nodding, which is great. So you'll see there, so like it's Stroke are holding some for us, we've got Thrive, and we've got our wellbeing team that are doing some for us as well, and they're taking place all over in many different parts, and that's just a little graphic I just put in there earlier. But we've created some of our own kind of social media and what we've done. So every venue, the light coloured blue picture on the right or the left of your screen, I'm not sure which way around it goes, but the light colour blue one, each of the venues have got a copy of that so they can share with their own social media and staff and service users and members of their community. So they've got an individual one with that. We've done a little bit of a cheeky overview one as well that they can put with that and also share the good news about what we're doing. We've also then shared it this morning and around the detail of where, you know, the pressure stations are, times, location on a press release that Holly and the team from North East Links Council have kindly put together for us, which has been great. So we're just really trying to hit it out in places that people trust, in places that people go to naturally. So, for example, the Learning for Life one on there, that's people that have English as a second language or maybe refugees to England and North East Lincolnshire that we're offering it in their classroom so they feel comfortable with their tutor to accept this. We're then doing another one within the YMCA. Again, they have 200 people that come on a Wednesday afternoon for a roast dinner. So why not put one in there that captures a breadth of people coming in, staff, members, residents as well. So we're really trying to think outside the box, and we have got some in Immingham, which I'm really pleased about as well. We've got some in the Civic Centre in Immingham, and we've also got some with our Live Well team that are doing another like walking group in Immingham as well. So really pleased about that. I think, is it over to Chris now for these ones, or is it over to Kate?
No,
Chris,
okay,
I'll
thank you so much. So I'm Chris Cook. I work with the North East Lincolnshire Council. I'm a public health officer, and it's just been, I just want to reiterate what everyone said previously, is that it's, I think it's one of those biomarkers that we can have a real impact on, that can probably have a real meaningful impact on that healthy life expectancy and life expectancy that we're seeing in some of our more deprived areas. And it doesn't require as much, the preventative side doesn't require as much discipline as, say, losing weight or quitting smoking. There's that element that, we can treat this medically. So I think this is, it's great that we're going to do Know Your Numbers week for a week, but I'm hoping we can use that as a platform to continue what we're doing beyond that. So that's where No Pressure, It's Just a Quick Check comes in, which is a joint project that's, it's in its infancy at the moment, but using the wellbeing workers in the council's wellbeing service, along with Thrive, along with any other organisations really that want to get involved in it, and trying to create a sort of standardised pathway for collating community screening figures, so we can know how many people we're getting to, and again, really making sure we make every contact count and taking away that fear and normalising taking blood pressures at a community level, but that it's non-clinical and it is, it's a screening with that referral pathway through to pharmacy, through to GP, an appreciation of that, and having that support network around it through either the British Heart Foundation's Heart Helpline, or through 111 if anything clinical is required out in the community. So with our wellbeing workers, we're focusing a lot on sort of smoking cessation at the moment, and the other angle we're using with it is that checking someone's blood pressure is I guess it feels slightly less preachy and a way of starting a conversation around their health, and maybe having that moment where they can sit down and take a moment, and it doesn't feel as canvassy, and that we're trying to just give leaflets out. It gets someone to sit down, engage in a conversation, and really start thinking about the well-being and health. And then it gives us that objective metric for saying, well, maybe we should look into our physical or mental well-being, and then where we can refer them through that. So that's the no pressure. It's just a quick check. Initial thing. Just go to the next slide for me.
Just on that as well, Chris, you
Yeah.
just reminded me. So with you saying about the want to carry it on, our group has wanted to carry this on, haven't they, afterwards?
Yeah.
And we've already got 2 big dates in our diaries for World Mental Health Day that's taking place at Centre 4, and also a Making It Real event. And what we're trying to do moving forward is any big events that any of our partners put on, we're trying then to have, even if it's because clinicians still have blood pressure, our staff still have blood pressure, so that's what we're trying to do. And the group has naturally decided to do that. That hasn't been forced from me, Chris, or Gaynor. That's just something that's come really naturally from our partners coming together, isn't it, on there?
Yeah, definitely. And I think one of the big wins as well is the end of the week, the end of No Numbers week is having a presence at the Grimsby Town match.
Yeah.
Which
Yeah.
I think, there's no real opportunity to get in front of the people that we want to get in front of, really. There'll potentially be 6,000-7,000 people there. We're looking at having 8 wellbeing workers, Thrive workers at each gate around the fan zones. So even if we get a tiny fraction of the people wanting to engage with it, again, it's appreciating that it's just a screen, it's not a diagnosis, it's not going to be a buzzkill on the match day for them. Blood pressures might be slightly elevated. It's take it all with a pinch of salt, essentially. But if someone's walking around with 200 over 110 blood pressure, you're potentially saving a life there, even if they are walking around normally at 180 or 170. You're getting to them at the time. You're making every contact count, and borrowing that halo from the football club, I think, is quite useful, because it then feels a lot less medical and intervention at that point. You're able to get them on a sort of social level. So looking at some of the work Barnsley have done with their community blood pressure screens. They did their How's Thy Ticker campaign, where they did essentially what we're doing here over this Know Your Numbers week, some targeted community screening. But when I looked at it and spoke with them, they never closed that feedback loop, and it's something I'm really keen on piloting. We're going to give people the results from the screen that we do, that they can then take to primary care with a QR code on it. So whether that's the pharmacy or the GP, that can then just close that feedback loop of has someone then gone to the clinician off the back of a community screen, and it'll just roughly give us some of those numbers to know. It's all well and good saying we've seen 200-300, we've screened 200 or 300 people. If we then don't know if they're going to primary care to be checked, they're going to slip through the cracks and end up like the people that Marcia was talking about earlier. So it's just trying to close that feedback loop. And I appreciate it's potentially going to create a bit more work for people that don't need any extra work put on them, but it is a QR code with a tick box, and that's literally it. And it should give us hopefully some numbers and some indication of are people coming through that community pathway for it. That's the end of my part.
Excellent. I think we're handing over to Katie next, I believe.
Yeah, Ivy, thank you. So hello to those who don't know me. My name's Katie Tennyson. I'm a pharmacist by background, and I'm currently the community pharmacy clinical lead at the ICB. Alison's asked me to talk a little bit about the community pharmacy blood pressure check service, or sometimes referred to as the hypertension case finding service. So apologies to those of you who might have heard this before. I think I could probably recite this in my sleep, but we'll go again, and anybody can pull me up on any things that I might say wrong or say differently to what you've heard before. So the hypertension case finding service has been delivered by community pharmacy. It's in its 4th year now, but the policy and context behind that happening, sorry, if you want to go back a slide. Thank you. Was about all the precursors that we already might be familiar with cardiovascular disease. We know, as Marcy has already highlighted, it's one of the leading causes of premature death in England. We know that it's the biggest risk factor for CVD, and we know that approximately 5.5 million people have undiagnosed hypertension in England, and we need to find them. We also know that CVD is a key driver of health inequalities, and there is evidence from locally commissioned community pharmacy blood pressure check services, as well as other services that community pharmacies delivered unfunded, that community pharmacy as a sector can provide a key role in the detection and subsequent treatment of hypertension. So it's about utilising all of the relevant stakeholders within our healthcare and wider setting to make sure that we are working collaboratively and innovatively to identify these people, to make interventions early at appropriate times. Next slide, please, Amy. Thank you. So like I've already mentioned, it's sometimes called hypertension case finding, sometimes it's called the NHS blood pressure check service. And the service is aimed to identify people who are aged 40 years or older, who have got high blood pressure and have previously not had a confirmed diagnosis of hypertension. This is at the discretion of the pharmacist, and people under the age of 40 can be included in the service. What happens is, where that blood pressure reading is high, they are offered an ambulatory blood pressure monitoring. If they refuse that, then the community pharmacy is obligated, as part of their service specification, to refer back to their general practice for appropriate intervention or follow-up. As well as that ad hoc or opportunistic, walk-in service that community pharmacy can initiate, community pharmacy can, at the request of their general practice, undertake ad hoc BP checks, but also ambulatory checks. So that can be for people with or without a diagnosis of hypertension. And it's also incorporated in the service specification for community pharmacy to use this opportunity, taking a blood pressure check, to promote a healthy lifestyle and early intervention. Next slide, please. So back when the service was first commissioned, it was only able to be delivered by pharmacists, and I think we'll all agree that any competent and trained person can take a blood pressure check, including us taking our own. Now we've moved on, thankfully, and the service can be provided by pharmacists, pharmacy technicians, but also suitably trained and competent pharmacy staff. So that means that other non-registered members of the pharmacy team can be utilised appropriately to deliver that, and it's important to utilise our skill mix. It is always the responsibility of the responsible pharmacist. It's a funny term, but that's a pharmacist in charge of a pharmacy at any given moment, usually during opening hours, to ensure that all tasks are delegated to suitably trained members of pharmacy staff. The service is usually provided on the pharmacy premises, but they can also be provided off-site. So we have seen our community pharmacies deliver the service at church events or community events, community groups, etc., as well as football matches and other sporting events. Where those off-site provision occurs, that has to be pre-approved by ourselves at the ICB. So pharmacy contractors do need some warning we're very willing to accept invitations to everybody, and they do go out identifying those opportunities themselves as well, but they need a little bit of notice to get their application into the ICB for us to review and approve it as appropriate. The other thing just important for people to remember is that the pharmacy contractor does have to have a suitably calibrated blood pressure monitor and an ABPM device, and that's selected from the set lists from the British and Irish Hypertension Society, and it's not to be shared amongst pharmacies, if that makes sense. It's not one ABPM per 10 pharmacies. They're each supposed to have their own, and that's what we see. Next slide, please. So just to quickly run through the inclusion criteria to offer that clarity as it's mentioned in the service spec. So for a pharmacist or a member of the pharmacy staff to offer and initiate that blood pressure check, that can be done for adults who are 40 and over who don't have a current diagnosis of hypertension, people who are under the age of 40 who might have requested the service because they've got a recognised family history of hypertension or another identified risk, and that's at the discretion of pharmacy staff. And patients between 35 and 39 years old can be approached by pharmacy staff at their own discretion. For inclusion criteria where they're referred by the GP and a referral isn't necessarily what we might define as a formal referral, such as the requirements with other community pharmacy services like Pharmacy First. It can be a group text message or a batch text message or email or other flash notification sent by general practice. So that can be for adults of any age with or without a prior diagnosis of hypertension. And that can be for either a clinic BP check or an ambulatory BP check. Next slide, please. The exclusion criteria is, so community pharmacy can't offer the service to people under the age of 40 unless the discretion of the pharmacy staff that we've already gone through, or they've been specified by a general practice. People who have their blood pressure regularly monitored anyway by another healthcare professional, people who require daily blood pressure monitoring for any period of time, e.g. as an alternative to ABPM, we might suggest 7-day clinic checks, and people who have a diagnosis of AF or an irregular heartbeat. Next slide, please. Oh, and I will just say before talking about the campaign, the current service specification for blood pressure check service is currently being reviewed by NHS England, and that might incorporate or introduce the ability for a community pharmacy to offer 7-day home blood pressure monitoring as an alternative to ABPM. What we tend to see is that patients who refuse an ABPM and by default means that they have to be referred back to their general practice, pushing the pressure back onto the practice to review and complete that additional workload. If we, as an alternative, could offer 7-day blood pressure monitoring as part of the service, then that may help address the low uptake. I also think it's important to work on the bigger education piece about ABPM. It's not scary. It doesn't have to be one for 24 hours a day. It can be for waking hours. It doesn't matter whether your general practice or your community pharmacy or anybody else suggests that an ABPM is needed. It all means the same thing, because I think sometimes people think they get it means different things in different places, which causes confusion. So consistent messaging is key. This is a comms tool, a link to a comms toolkit that Alison, myself, and some other ICB colleagues have developed for community pharmacies. So that has been shared with all community pharmacies for them to help contribute to the Know Your Numbers campaign for this year. I think Alison's just popped in the chat the link. So if I can say next slide, please. Focusing specifically on North East Links, there are 32 pharmacies in North East Links Place, and all are registered to deliver the hypertension case finding service. 31 are actively delivering it. There is one that isn't at the moment. We believe that's to be down to some staffing changes and training and staff moving on, but that shouldn't be a permanent thing, more of a temporary thing. I don't know if anybody's familiar with Shape Atlas. I find it quite a useful tool for understanding where everybody is, but you do need an NHS email address, and you can actually click on the pharmacies to bring them up on the map and look at the blood pressure check data, as well as contraception service data and Pharmacy First data for each pharmacy, with the caveat that that data is not live data because it's based upon the data set from the BSA, which is about a 3-month lag time. So it's currently data up to April 2025, uploaded in July.
It's a very clever tool, isn't it, Shape? And we're doing some work within our healthcare partnership on Shape to look at potential gaps and what areas are missing what within our certain and different wards that we're working in. But it's mind-blowing. You can get bus stops, you can get absolutely everything. It's such a clever tool, isn't it, Shape? It's brilliant.
I think it's very underutilised, and I encourage anybody to go and try and sign into a training session, because like any technology, we're probably using about 5% of its functionality. We're unaware of the 95%, which might be the more useful bits. Next slide, please. So this is just a screenshot to show you the data at place level in our 6 places in Humber and North Yorkshire. North East Links has always been the highest performer from a community pharmacy perspective. So it has the highest number on average of BP checks by 100k population. Next slide, please. Again, just a different way of showing similar data, or pulling the data in a different way. If we look at North East Links, so year to date, 3,500 blood pressure checks have been, opportunistic blood pressure checks have been done in by community pharmacy, and 753 have been referrals. There's been 238 opportunistic ABPMs and 352 ABPMs that have been referred. I think that just demonstrates that North East Links, from that community pharmacy perspective, there's some good working relationships there that need to be showcased, or a light shining on between general practice and community pharmacy. And I would actually congratulate North East Links for having one of the highest percentages as well, along with its neighbour North Links. But we won't mention them because we'll focus on North East Links. In England, if you look at the, if I'm looking at the column in the red at the bottom right-hand side about percentage of opportunistic ABPMs of opportunistic checks, normally the England average is hovering around 4 or 5%, and North East Links is already higher than that. So I think that demonstrates that where community pharmacy is doing blood pressure checks, we expect about, for every 10 blood pressure checks to be done, about 1 ABPM to be needed. So we're not there yet, but we are further ahead. So again, it's about sharing the practices and learnings from North East Links and wider to make sure we're maximising opportunities. Next slide, please. Just as a parting gift to you all, so I'm not talking solely about hypertension case finding. I think it's also important to highlight the IP Pathfinder programme. IP stands for Independent Prescribers. So from the 1st of August next year, 2026, all pharmacists, when they first register with the General Pharmaceutical Council, will be independent prescribers in their own right. Approximately 70% of the pharmacist workforce currently is based in community pharmacy, and there is currently no NHS commissioned service to allow prescribers to offer a prescribing service from that community pharmacy setting. So the IP Pathfinder programme started way back in 2022-23 for ICBs to submit an expression of interest, and Humber and North Yorkshire did, and we were fortunate to have funding awarded to us for 10 sites. We have 3 of those 10 sites are based in North East Links, and that means that we're currently delivering a number of different clinical models, 2 of which are CVD based, about how can community pharmacists who are IPs deliver an integrated clinical service incorporated into that wider healthcare setting, to make those early interventions and meet the population needs of those local communities. That's in order for, that will run until the 31st of March 2026, and that's to inform the development of a commissioning framework, both at national level, but also importantly at local level. If anybody wants to know more about that, I apologise, I am a broken record about it. Please feel free to email me. Otherwise, I think that's my last slide, Amy, but you might want to tick it over just once and I'll be proved wrong. Yeah, proved wrong again. Yeah. Maybe this one's the next slide, the last slide.
This one is, you've got this and a useful links, and then that's it.
That's fine, thank you. So it's just to highlight, I'm sure we'll all have read the 10-year plan back to back and looked at the inside of our eyelids. But just to highlight, I certainly, when it first came out, I do what many of you will probably do and do Control and F and search for the keywords. So my keywords were always community pharmacy and prescribing, and I've just pulled out this paragraph because what we hope to see is over the next 5 years of the 10-year plan that community pharmacy will transition, instead of being focused or dependent on the income predominantly on dispensing medicines, to being integral to a neighbourhood health service and offering more clinical services. So where we do have, and we will have, independent prescribers more available in community pharmacy, we're actually utilising their skills and not de-skilling them at the point of day one to make those early interventions. But we also need to ensure that we've got a commission service that facilitates that. And we know that the Yorkshire and Humber Care record, it is on the roadmap for community pharmacy to be joined up to that, which is essential in order for us to, like, community pharmacy sector, to provide a safe and effective service. So the last slide is just a link of a slide of summary of useful links. So I'll let you click through at your own leisure. It's just me pulling together a lot of the information available at Community Pharmacy England and NHS England all together about the hypertension case finding service. So thanks for listening to me today. I think I'm passing back to, is it Amy or is it Alison?
I just wanted to say thank you. It's really informative and really interesting. And I'll just stop sharing because that was the last slide. I'll pass over to Alison and to see if there's any questions while we still have everybody here. Here we go. So we have got Thomas.
Hello, hi. Hopefully you can hear me okay. Lots of familiar faces on this call, which is lovely to see. I guess the question is, we know the scale of the problem amongst us all. We know that it's a massive problem, and there are different ways of cutting up the data. It could be 9,000 people, it could be nearer 20,000, depending on which percentages you use, etc., etc. It's irrelevant, really. I guess what we know, there are thousands and thousands of people across our ICB with hypertension and no diagnosis, or with hypertension and a diagnosis and not treated to target. And it's a bit of an impossible question, this, but what can we do to do more? Because all of the things that I've heard today are absolutely fantastic, and we should absolutely keep on doing them, and we should do more of them. But it almost feels like it's probably not going to be enough, is it, realistically? Like, if we looked at how many new hypertensives were diagnosed each year, I haven't done this, but I suspect we're talking thousands of years before we even get to the point where we've diagnosed those who are now long dead. So what can we do to ramp up the pace? Is it within our gift locally? Is it a national thing? What can we, just throwing it out there, really, amongst friends. What do we all think?
Marcia, do you want to try and answer that?
I suppose it's interesting that recently there's been a clinical leadership cull locally. So, there's all sorts of ICB cuts. So lots of the clinical leads for different things have gone. But they have still kept quite a significant amount of clinical leads for cardiovascular disease prevention, because nationally at the moment it is a big focus. So I think that will help, because when it's a priority for NHS England, then usually that leads to a kind of focus of priority in terms of funding coming down and in terms of national campaigns and support. So that's the first thing. I think the second thing that's really struck me, and I think the Train the Trainer project that Gaynor spoke about is a prime example of this, is I think what we have had blood pressures in community pharmacies for a while. We've had, GPs taking blood pressures. And in the end, if GPs could have done it on their own, we'd have done it on our own years ago. I absolutely agree with you. But I think this use of non-medical people to take blood pressures, people who aren't medical at all, our social prescribers, getting people who are seen very much outside health into parts of the community on a regular basis. We've done these projects before where someone's gone up to Grimsby Town and taken a blood pressure, but it feels now really like this is a much more sustained effort to me. I don't know about anybody else, but it really feels like it's kind of got under everyone's skin. And with the Train the Trainer as an example, that's got exponential kind of potential impact, because these are people who are going into some of the most deprived families in the area with some of the greatest breadth of needs, social needs, etc. And once one of them is trained, they can then train almost an infinite amount of other people who can then train an infinite amount of other people. And like, for me, that's the sort of intervention that we need, so that it just grows and grows and grows, you know. And then even if, you know, you're taking blood pressures from people, say at Grimsby Town, like we say, and they're excited and they've been boozing, so you're going to get some false positive. I think just raising that awareness, you know, just almost, we've got to be like a dog with a bone in a way, and just keep going and keep going and keep going, because what's the alternative? You know, we just have to keep trying, don't we? So for me, this feels a bit different. It feels like the tide's turning a bit, but I'll be interested to see if anyone else agrees with me.
I think we've got Gaynor and then Alison.
Yeah, I agree with Marcia. I think it's a case of water dripping on stone. We've just got to keep going and going and going and going, and you know, because this didn't happen overnight, and we're not going to get rid of it overnight. And until we've actually got societal change, until we've got change that's coming in the form of policy, government policy, and I don't know, looking at poverty, looking at lifestyle choices. It's, you know, it's a wicked problem, isn't it? And it's not, you know, it's got so many components to it, and certainly we can't solve it alone in health. It's got to be about the wider social determinants, and it's got to be a complete well, it's an overhaul. It's about the way people live their lives and the way they've been accustomed to living their lives. And that's a big axe to change, but it doesn't mean that we can't start somewhere.
Yeah, absolutely. Alison?
Without re-emphasising what everybody's said, obviously, I agree with all of that. I think it's about maximising our resources, carrying on doing what we're doing, you know, working collaboratively, bringing things together, having the opportunity like today, Amy and Gaynor, to come and talk at Community of Practices, share that learning, that good practice, hear the stories. We also would welcome coming back later in the year. We're running a behavioural insight project across the system. We benefited from some funding at the beginning of the year to do a CVD behavioural insight project. So we've commissioned VCSE organisations to go and have face-to-face conversations with some of our populations that we know are at greatest risk of cardiovascular disease. And so we're just sort of starting to bring together some of that feedback from those conversations, which will culminate in a report later on this year. So we're not just we are asking what some of the challenges are, but we're also asking and what would good look like, or what would different look like. So we're hoping to be able to tease out some of those solutions, if you like, from some of those conversations, as much as we sort of understand some of the challenges to that. So that'll be interesting, I think. We do, and I'll put it in the chat, we do have a survey, a digital survey that's still running as part of that piece of work. So we'd welcome you. I can put it in the chat if you were able to share that across to your organisational comms channels as well. As many of these surveys that we can get completed to help us understand CVD prevention and some of the challenges and opportunities, the better we'll be at being able to answer some of these questions that we're posing. But for me, it's about making sure we maximise the resources that we have at hand and thinking about how we can work collaboratively and differently, I think, and based on some of the learning that's gone before us. I think we don't need to reinvent the wheel all the time. There's some excellent examples of ways of working across the system. So thank you.
Just on that, Alison, since I've been sending out a plethora of emails this morning, I've actually had Fiona Wilkinson from the Stroke Association contact me about that. And she's actually coming along to some of the pressure stations and talking to people at the pressure stations about that work that you talked about there. So that, again, just by sharing that knowledge, we're again opening that out to more people, aren't we? So it's just about that share and that partnership working, isn't it?
Yeah,
Sally,
absolutely.
Oh, sorry, Alison. Thank you. Sorry, Sally. Sorry, I jumped in there. I do apologise. Oh, you're on mute, Sally.
All right. Yeah, no problem. I mean, I agree with what Alison's and Gaynor's just talked about and just done about the wider determinants of health, and this being a sort of a whole system approach rather than just a clinical approach. And you know, I just think back to, there's some things you can kind of do by stealth. And I know this is a strange example, but it's just sprung to me because I used to live in Canada and we had a referendum about this, because we used to have referendums all the time. But they actually had a referendum about putting fluoride in water because of the impact on tooth decay. And that actually was proven to have a significant impact on dental health, even though it wasn't a lifestyle choice. It's in your water, you've got no choice. And that, if you transfer that on to sort of the causes of hypertension, it sort of makes you think, well, it's all round us, you know, fast food, unhealthy options for food. And if we're and looking at the Marmot Council approach, maybe being really, really, really more positive about nutrition and health in food choices. So our cafes and our local restaurants get a big woohoo if they're I don't know, a heart healthy restaurant, but they actually start to supply food that is lower in salt, or, you know, just things like that. So it becomes not, you don't have to go out your way to eat healthily. Like, you don't have to go out your way to eat fast food because it's on every street. You know, when we have our community events and fairs and that, how many times do we have a burger van? Because we think, oh, we need to make sure that we've got some food for people. So I'm just trying to think about our catering when we make a decision about caterers that we're going to get for our events and that. So it's just a thought about the whole nutrition and lifestyle it's something that I think has got a business impact as well as health. So it's just an idea. I haven't got the answers. I just floating a few ideas there.
Good ideas. Thanks, Sally. I think we've got Gaynor next, I believe.
I think no. I think
sorry,
it's Marcia than me. Yeah,
Marcia. Sorry, there was a speech bubble over, so I didn't know which way the arrows were going then.
So I think I was just sort of coming back on Sally's point. I think it's a really good point, and anybody who's known me any length of time knows how I harp on about kind of ultra processed foods, and I think I've read recently a Canadian paper on the science of obesity, and again, obesity is another problem that's not well dealt with uniquely within health, but needs that kind of multi-system approach, and again has the same issues with societal change being needed. And there's a quote in there which I thought was really interesting, where they say, yes, lifestyle is seen as a choice, but when you look at these unhealthy choices, they're really unevenly distributed across the population. And those what we would see as the poor lifestyle choices are definitely seen more within the more deprived deciles. And you've got to question why that is. And we know, those of us who work in places like the non-sub estate where I work, we know that, you know, Heron Foods is just about the only place on there, and it doesn't have a great selection of fruit and veg, for instance. We know that there's loads of takeaways and pubs and not really some of the opportunities that some of our more wealthy boroughs would have for sort of healthy shopping and cooking opportunities, etc. So I would absolutely agree with that. You know, there is that kind of widespread societal change, and you know, some of these problems are so broad and so deeply rooted, aren't they, that they almost seem unsurmountable. But I think, like Gaynor said earlier on, we've just got to chip away, because the alternative is that we do nothing, isn't it? We just say, oh, this is hopeless, and we sort of throw up our hands. And I think what we have to remember is that, yes, when you look at things from a data level across our area, it all seems very difficult and very unsurmountable. But I think everyone's got an example of where you got really involved and really invested with a family or an individual, and you've managed to make that change. You know, I did a bit of a project recently with the social prescribing team around our diabetic patients, because we were underutilizing them. So when you get diagnosed with type 2 diabetes, which is the one that more adults get, which is more associated with lifestyle issues and can lead to cardiovascular disease. But when you get a diagnosis of that, you're supposed to be referred for this Desmond, which is like a structured diet program, which has been proven to actually, you know, help with diabetes. But most of our patients were refusing to go. we hadn't really explored that, but actually when we did explore it, it came down to the fact that they didn't feel that they were very academic, and they didn't feel that they would be able to participate in it. And also we hadn't really taken the time to explain it. We were sort of ticking the box, we'd offered it, they'd refused it, etc. So when we actually then said to them, okay, well, if you don't want to be referred to, we'd take some more time to explain, but if you don't want to be referred to Desmond, how about going to social prescribing? Because we know that our social prescribers are trained in Desmond, so they can actually give some of the advice, but also that they have iPads and things to help people who don't have online access to do the online training, and they're even starting to look into delivering the training themselves soon. So we started to do that as an alternative, and one example was we had a patient who was refusing to engage with us in healthcare, wasn't taking his medications despite our best efforts, wouldn't come into diabetic appointments. And somebody went and sat with him on his allotment every week for weeks and weeks and weeks, and slowly but surely built a relationship with him where he's kind of like started to engage now. And that's not something that we would have had time to do within primary care. And that one case, that's not going to help our figures for the area. No one's going to, you know, slap themselves on the back and say how wonderful that is. But actually, for that individual, it could be life changing. So I think let's take the anecdotal wins. Let's focus on the individuals in front of us. Let's try and do the best job that we can for them. But over time, let's try and build a strategy that helps us to address, you know, to contact as many people as possible and make those contacts count, like we said.
Yeah, brilliant.
Sorry,
Should we? Sorry,
do you
Gaynor,
mind if I come in?
Yeah.
Sorry, Tom. I put my hand down by mistake, and it is just linking into this. So if you don't mind, thank you.
I'll let you off.
Just a couple of things. So we do have a whole system approach workshop that's going to be taking place around weight management in North East Lincolnshire, and I'm meeting with Lindsay Hudson from Public Health to start planning that later this week. Also, with regard to your fast food outlets, it doesn't matter where they are, because you don't have to go to them. They bring it to you. You don't even have to walk there. All you have to do is get off the sofa and go to the door. Yeah, so that's what we're up against. That's where we are now, you know, in this terms of it. And Sally, Public Health have tried to engage with food outlets to make things healthier, etc. And I'll have a conversation with you about that, about the challenges.
I can imagine.
Yeah.
Thanks.
But aren't they called the commercial determiners of like health as well? Like and I went to a brilliant kind of conference where there was a speaker last year. It was, I think, Tom and Gaynor, and that was fascinating about how they put particular foods by, you know, the tills, how things are in certain reach, how the colours correspond to children to grab, even to adults, you know, and it's that psychology now of what people are using as well, isn't it? But like you say, Gaynor, like, I mean, I live right near KFC, Taco Bell, all of that. But if I didn't, I could go on Deliveroo. I could go on Just Eat. I could even do that, even though I'm a 2-minute walk away, and that's super lazy. Do you know what I mean? So it is that fight. And then you get offers, don't you? £8 off if you order tonight, £10 off this one. So it is a lot of commercial determiners that we're fighting against as well, isn't it? Sorry, Tom.
Yeah, just feel like I should do my. Seeing as we're talking about fast food, I love fast food. I love a dirty kebab and all the rest of it. What I will say is, obviously, those things should be enjoyed in moderation. A lot of these trendy cafes that serve, I don't know, Turkish eggs or whatever it is that trendy people eat. Sometimes they can be just as bad for you as. It might not be as processed, I don't know, but you know, in terms of calories, they might be just as calorific just because it's organic. No, so what I was going to say was I really like to watch the Hotel Inspector with Alex Polizzi, and what she does is she has she goes in, looks at a hotel that's performing badly, and then she ridicules and embarrasses the owners by saying, what's your occupancy, what's your cost per room, etc. And I sometimes feel like we, the collective we as a group of people, as an ICB, as public health colleagues at the council, we probably don't know how many new cases of hypertension are being found each year. So we probably don't really know the scale of the problem, or how quick, or we don't really know how long it's going to take us to solve that problem. And that's probably a bit unfair of me to sort of throw that question out, but I am a lot of the types that train the trainer. I think that's, you know, that's obviously in value and reward. Well, is really valuable. I guess some of the bigger questions are in terms of the money associated to cardiovascular. There isn't a lot of it, is there? You know, within the ICB, there isn't a pot of money for solving this problem. So maybe, and thinking about business, thinking about the commercial determinants of health, maybe we need to get better. We collectively as a group, not necessarily as an organisation, need to get better at working with some of the people who hold the money, and that could be industry, by which I mean diagnosed. Maybe we should work with them a little bit better. I don't know. I mean, just spitballing ideas as well. I was thinking, how many patients does a GP practice see in a month, face to face or through the waiting room? How many of them get a blood pressure check? Probably, I don't know. And it'll be different per practice. Some practices will be really good at this, others won't. And there's very good reasons why not every patient would get a blood pressure check. But if you were to say to general practice, for every patient you do a blood pressure check on, you'll get the same amount of money that community pharmacy gets, I imagine every patient would get a blood pressure check. So what can we do to shift the money around? How can we make this work? Because otherwise, and it's probably because we couldn't afford to pay general practice that. And actually NHS England, and I'm on a bit of a rant now, aren't I? NHS England probably doesn't want community pharmacy. You know, how do we fix this? What can we do without, just throwing it out there, having a rant?
You see, I think for people like outside of these kind of virtual walls or where we work, people's minds would be blown that GPs would get paid extra for doing something that they technically should be doing anyway. And I think that blows people's minds. And I think that blows my mind, even though I've worked in this world now for nearly 2 years. So I think it's about, like we say, making every opportunity count. I think it should, in some ways, regardless of time, it should just be like a standard thing, I guess, that it's done, because it's not like you've got to draw blood. It's not like you've got to then take it for testing. It's a very less risk kind of thing just to place a cuff around an arm and get a reading. It doesn't cost, once you've bought that machine, other than the time to do it, it's not a costly endeavour either, is it? Because you aren't going to take it to the path lab, you aren't going to do this, you aren't going to do that, you aren't going to do the other. So I suppose for me, it blows my mind to think that we have to pay GPs or doctors or practitioners to do something that should be done. I suppose that's my kind of thought on that as well. I don't know if anyone else has got any thoughts on that, or if I've just blown everyone's mind. But yeah, it's just an interesting
I just
one,
think it's just great, isn't it, that we're able to have this conversation that we've had today. Stimulates so many thoughts, doesn't it, in terms of the answers and some of the challenges that we're talking about. So I in particular have enjoyed this conversation and all the points that have been raised here today. Let's keep the conversation going. We'll be happy to come back with some of the results from the behavioural insight work that's been undertaken, which again I think should sort of snowball some more thoughts and views about this. We do have our CVD Prevention and Detection Network meeting, which partners, if you want to reach out to me and join that network, this is where we share some of the thoughts and raise some of the issues that Tom's sort of raising. And we are having a session on the 1st of October in person to talk about some of these factors and how we set our priorities for the next 2 to 5 years and longer in the context of the NHS plan that's just come out. So yeah, I'm really enjoying this. Let's not lose track of these comments and thoughts. We might not have all the answers today, but we need to keep talking about it. So I appreciate that.
So what we'll do, we'll just go to Marcy, then Eric, and then we'll kind of close and let ourselves make a cup of tea, have a move around. But thank you again for everyone for coming along. We'll go over to Marcia. Thank you.
Yeah, it was just to come back on your point. It is really frustrating if I see that a patient's due a blood pressure check or needed a blood pressure check and they've come to the surgery for something else and somebody's not realised and they've come and gone and not had it. And that is frustrating. But of course it happens, you know, when people are coming in. I mean, anybody that came in for anything medical would probably have a blood pressure check anyway, but often they'll come in because they're having a dressing removed after being seen at the hospital for something, or, you know, and the nurse just won't think to do it. Yeah, and in terms of GP, it is part of our core contract, obviously, to check blood pressures and things like that. I think usually where GPs are paid extra money, it's around if there's it's very much up to each GP how they meet their core contract obligations, and that will vary because we got slightly different populations. So how it's done in healing, GP there might not work up and I think primary care that we have, as long as we meet our core contract obligations, that we can do it slightly differently in different neighbourhoods. But if there's like a big organised project, so someone, say, from the ICB said, right, well, you know, we want to do this big thing and it's going to really increase your workload over a short period of time because we want you to deliver it in exactly this way, then that's often how, you know, GPs would then be paid extra to deliver that service. So that's usually why extra money comes in, because something's been organised in a very sort of specific way, which is going to put extra demands on primary care in quite a short space of time. But yeah, certainly it is part of our core contract. And we should be doing it.
Checked everything, so they are doing a good job at Raj. So that was at Raj, so they are doing a great job. Over to Eric.
Yeah. Good, you know, with all these whole system approach, it's very fantastic. My question is, in the people in the rural areas, how is this service reaching out to them? Also, in the rural, it's so difficult in terms to services, and how these services is reaching out to them. As NHS health check. And then my last question is, that is addition anyway. I think in some of these services will also be helpful in terms of the local libraries. And some places in London, they use this model that called barbershop approach, which is also something that they pick it from United States. And now UK, some of the places who normally go for barbershop for cutting their hair, normally in terms of health, they talk them about health promotion. And I think that could be another place that can be targeted as well. And Canada is so fantastic in that, you know, high blood pressure. I think that was a model that in some years back, we wanted to, you know, use the same model. Yes. So thank you.
Are you okay to answer some of those?
Yeah, I will certainly try.
Thank you.
So Eric, I think when you're talking about the rural areas, for us in North East Lincolnshire, it isn't particularly something that we have to deal with because we're a very small unitary authority. Yeah. So the population of North East Lincolnshire is probably about the population of York. We don't have, you mentioned the practice in healing. The rural areas tend to be where people are more affluent, and so we probably don't have, you know, undoubtedly there will be some issues, but we don't experience it like they would, say, in North Yorkshire.
Yeah.
And then with regard to the barbershop model, I think it's brilliant. I'll say targeting particular communities. For example, the Black communities in London. Yeah. Again, North East Lincolnshire, we have quite low diversity. We don't have those established communities as we would in cities. So I think what we really need to do is we look at areas like the East Marsh, the West Marsh, South Ward, you know, where Marcia's practices, and actually look at those where we've got pockets of high I think we are quite different to other areas. I think probably we're more similar to Hull than other places. So and the health checks. Sorry, what was that about health checks?
The health check. I think Katie made mention about NHS blood pressure check, and we also have NHS health check. So I was thinking, is this kind of
the health checks are in GP surgeries, so they're a funded check where we check various things, like we take some bloods for cardiovascular risk, you know, things like lipids, and we would check a blood pressure and height, weight, and give health advice about different things. So there's particular things that are stipulated in that check. It's a very sort of regimented, certain boxes have to be ticked to complete it. So yeah, that's usually performed by GPs in the GP practice.
The primary care is commissioned by the council, you know, as Marcy said,
we're doing that, but I think it was, you know, the pharmacy ones is quite very interesting, you know, because this is the NHS one that I think is opportunistic screening that, you know, if you have, you know, if you're not diagnosed with diabetes or high blood pressure and you age 40, then you have that, you know, eligibility that you can check. Yes, you know, but I was thinking the pharmacy one is quite very interesting and easy to implement to catch a lot of population that they may have the high blood pressure, but they have not checked. Maybe they could be, you know, so many reasons.
I think as well, Eric, when we talk about Know Your Numbers Week, that's about raising awareness of people being able to take their blood pressure at home rather than relying on particularly GPs and, you know, and pharmacies. So it is about that awareness raising. As Marcy said, you can have a very
killer.
So I think Katie, just the last kind of in the chat there. So she's just put in around East Riding are commissioned to deliver NHS health checks. Pharmacists are due to the rural parts of the area, and previous pharmacies in Hull were commissioned to do health checks as well. So that is maybe a way of tackling people living in rural communities. But I think that's a brilliant way to end. 10 minutes extra on people's time to get a coffee or a tea or a juice or some movement into our day. I've been standing up using my standing desk, so that's been pretty good. So just wanted to say thank you for everyone for giving their time. It's been really great conversation. By the end of the week, I'll have it shared, and all the links that you've put in, I've been saving them. And I'll put it in the email to share with everybody in our extended community of practice. So remember to cheers. Bye bye. Bye bye.